let's go. So you probably know all about methane, not the gas, but the methane report that we have to give. So some of the more junior registrars, you probably did not do the disaster course yet, but you'll get into all of this. This is something to have in your car and or on your phone to remember when you stop at a big accident, and you must give the methane report. This is just some pictures where we say how to manage a big major incident on the outside, like a pile up of cars or any fire in a informal settlement, something like that, and you're the first to arrive, how to organize that. And we shouldn't forget CSCAT. CSCAT is for command and control, safety, communication, assessment, triage, treatment, and transport. But there is so much more to major incidents and disaster medicine, and so I want to give you a few other aspects and other perspectives on things. You'll learn all about these other things I just mentioned. We're going to not talk about them this afternoon. So the aim of this afternoon is to give you a short story about writing a major incident plan for your future facility. And that's something I've done now 3 times after I started my job here. So it is something that you will probably be asked to get involved in. We'll get into that. Then the second part would be quick highlights from the pre-reading. I'm going to first ask you what you thought of the pre-reading, and then also just give a few highlights that I thought. Then the third part is we will break out into groups and we'll chat about your experiences, also specifically in terms of COVID and your units in hospital, what you've experienced. That's really to share a little bit with each other. There's no right and wrong answers, but also we want to learn from each other. And then we'll end up with something for the exams. Maybe I see Heike also joined, so maybe she can change the question or give a different version of the question that I want to suggest, and see, just to make you think about an exam question, either written or even an oral question coming from this. Okay, so the scenario is that you just started at your hospital as new consultant. They just had a small fire and realized the hospital does not have a disaster plan or a good one. They know disaster medicine is part of your expertise, so ask you to write a disaster plan for the hospital. How would you approach it? There is a hint that your hospital is also located next to a large soccer stadium and a very active taxi rank. So let's see. So this is a little bit my story, how to or how not to write a major incident plan for your hospital. And just a few pointers on that. I'm going to look at different aspects, and the first aspect is internal versus external major incident. So this is something I think I made up. Maybe I read it somewhere and then internalized that, but to just think, if you write your plan, try to, as early as possible, make a distinction between the 2 kinds of major incidents. Internal, basically threatening the functioning of the hospital, and it can be something like a fire, because we've had a few, or a bomb threat, or a bomb. Some hospitals have experienced floods. Yeah, so I must say, other than EC, the rest of the hospital only thinks, if you say major incident plan, or many people would say still disaster plan for the hospital, they will think of internal. They will immediately come up with something saying, oh yes, to evacuate the whole hospital. How do we do it? Is that what you are talking about? And yes, fair enough, we are talking about that, but there's also something that we are quite involved in, and that is, as ECs, we are very involved in the external part, and that is the whole aspect of having surge capacity and in a moment's notice creating surge capacity and initiating an external major incident plan for your EC and for your hospital. So very early on, when you speak to people, talk to them in these two terms, internal and external. And last week still, we are going through a very good process at the moment with Mitchell's Plain. I had to challenge the CEO because the CEO was saying, oh yeah, this and this and this. And I said, oh no, but we're talking about the external major incident plan now. We took a few minutes to talk about that. And she had to say, oh, yes, I understand. It's not about the fire and how to sort out the fire in the hospital, but rather the external major incident. How we now did it at Mitchell's Plain, we have external major incident part of our plan and the internal major incident. It's what I said already, just to make it clear that those two are separate. Obviously, what I'm not yet saying is the internal major incident, like a fire, can quickly develop into an external major incident aspect also, or a surge problem, because if you have many patients from the fire, then the EC will be involved in initially at least stabilizing these patients coming from the fire that has happened in your facility. So just to remember that you'll have to quickly shift gears sometimes if that is needed. So the drivers of this process, you can ask, who, me, and why me? I think who, me, and why me is a good question, but you are probably the most appropriate person to head this. And you've got the expertise, you've got the interest, and you probably have the passion for both the internal and the external major incident. Certainly with the external major incident, as we discussed last week, it's basically the EC that has to spearhead all external major incident things, and it's just the rest of the hospital that then gets drawn in afterwards, because you need to create capacity in the hospital for the surge of patients. But so it's actually good that you are involved in the writing of the major incident. Sometimes it's you that are just I'm teaching. You are involved because it's a good idea also to have input, many times input in how things are going to happen. The hospital leadership is very key to this process, and I think I wrote the major incident plan or revised it about 2 years ago, and I think if I think about this time around doing the major incident plan, it's so much better because the hospital leadership was really involved, and I'll get to another point there later, but yeah, it's important that they drive this thing, because we'll also get to that. It must be alive. It must be a thing that is kept alive, and people should be able to think about it every day. The OHS practitioner, I spoke to our OHS practitioner, Occupational Health and Safety. She says that at different hospitals it's done differently. So the safety part many times are not done by the occupational health practitioner of the hospital. So there's someone else doing safety, and that person then will be very responsible for training of firefighters and fire marshals, those kind of things. But just figure out that quite early. How involved is your OHS practitioner? Because he or she can be quite a good partner in in figuring out things like training and filling in lists of fire marshals and evacuation marshals and things like that. The buy-in, to keep it alive, you really need to know your role players. Some interesting things, the nurses are very keen, and because it's part of what they do on the wards, for the internal major incident, for evacuation, for firefighting, they are very much involved. And they usually have also some kind of major incident wall or a document that they keep there, and they are involved in teaching the nurses also to be assigned every day to a fire marshal, for example, things like that. The doctors are quite important but difficult to get involved. They are not so keen to be involved because if you ask me now, an orthopedic surgeon, why would they have to be involved? I think, yeah, if we can spearhead it and work with the leadership and work with some of the nursing staff and the OHS practitioner, that helps a lot. Admin, don't forget them. For example, our admin whole block doesn't have good exits, so we had to rethink all of that. So no good escape routes, really. Allied health workers, important. Big areas. Our ground floor, we've got a big ground floor with many, many different departments, and we have to think about each one of them. Supply chain, sometimes there's flammable stuff there that we must think about. Maintenance, the chief artisan, that's the title of that person, very quickly involved in any major incident plan, especially the internal part. So keep that person close as your ally, and you can get a lot done. The outsiders, what I mean by that is these are actually outside companies that work for the hospital and inside the hospital. So I had some good chats with the head of NHLS here. They've got some interesting things, like they've got a cabinet for flammables that they can put their flammables in as soon as they are alerted. They've got a fire blanket that many other places don't have. And they also have, from corporate, they have their own major incident plans that they have to implement. So these two things must come together: a major incident plan from the corporate, from the company, and then also must be integrated with the wider hospital plan. So some pointers there. Action cards, it can be a valuable ally, as I've seen this time. I wasn't so keen on action cards in the beginning, because I think people just have action cards and then they don't do what it says in any case. But this time around we took a bit of a different way of doing things, and we decided to get people involved in the whole process. We would ask every department, clinical, non-clinical, wards, others, we would give them a generic action card for 3 key people, and that would be the person in charge, the fire marshal, and the evacuation marshal. Some people added even other roles, and that was also a good thing and a very good initiative from some of the departments. But then we would give them generics, just to give them some guidance on these action cards, and they would then go and change it. Deliberately, we left some stuff in, like vertical evacuation, where they are on the ground floor, just to see that they understand that this is now only horizontal evacuation. So we kept it in there, and then they had to come and present it to the hospital EMT, so the chief structure of the hospital. So they had to basically come and say how they would adapt it and make it their own, their department specific. Why I say Silver Command, who is going to jail again? The thing is that if we are very keen to get involved in these things, but as I learned on the ship, my short stint on the ship, it's actually the captain that's going to go to jail eventually, and we are there to keep him out of jail by doing good things like having good plans in place and doing the right things. But it must be the CEO eventually that carries many of the responsibilities of, if possible, to make the call of a full evacuation of the hospital. Because otherwise, people can die just by being evacuated out of the hospital, and who's going to take responsibility for that? So Silver Command, it's actually important that there's a CEO involved, and we as EM people, we should rather support them than necessarily take over the role that they have to do, and also the legal liability that goes with that. EC, we obviously have a big role to play, and external definitely. The wards and many other departments, they all have to have these three key people at least to work when it comes to it. I spoke to the generic to the specific. The wards had to, the different departments had to adapt these generic action cards, and it was a good exercise for them. Yeah, and we are hopefully making this plan come alive because of the input and the buy-in of these different departments. Another aspect I thought of, and that is, don't forget the ideal hospital document and what we have to do. There's so many things. I'll show you a few. There's actually a whole chapter. This is a chapter, subcomponent 37, disaster and emergency preparedness. So the point of the thing is, if you write your major incident plan, then sure, if you don't take these into account, ideal hospital will just come along and say, oops, you're not compliant because you didn't look at element 284 and you didn't write that in your plan, or you didn't implement it in your plan. So to remember just to think about the ideal hospital and to be compliant, it's actually I think it's quite a good general document to guide hospitals and clinics to what keep in mind, and why not look at it, and obviously if you're compliant, then it's not a problem. So to keep that in mind. Yeah, there's just more and more. So they give you the guidance on emergency evacuation drill is practiced annually. So you must do something annually, and you must show the proof of that. So that must be written into your plan also. This last one, hospital-specific risk are identified. It's actually a good exercise that we went through also recently. It's also, I think it's to be compliant, but we went through it, and every department had to say what are the risks that they can identify, and it's things like, lots of patients to theater that we had to go through a whole process of saying that if they've got 4 people on the operating theaters getting GAs, how to evacuate them. Just on that, if we evacuate them, we agreed that they will, in our situation, specific situation, they will probably evacuate to resus in EC first, and if needed, they will then evacuate further. So at least to be able to have a place to go other than outside there in the sun with intubated, ventilated patients. So yeah, so I'm also quite aware that if someone from Tygerberg or Groote Schuur listens to this talk, they will say, hey, it's a different scale that we're talking of. But for a small hospital or a smaller hospital, it's quite doable to find a practical way around these things. And maybe the idea is for theater to horizontally evacuate to day surgery, and then if needed, if they can't get control of the situation, to evacuate to EC, and then from there. So the previous plan or other facilities plans, you can certainly look at it. Copy and paste is a dangerous thing, because I had to write the plan also for Heideveld Emergency Center. It's the other hospital, and there the previous plan talks about ground level and first floor, and what was the other thing? the switchboard, there's nothing like that. There's only a ground floor. So be careful to copy and paste. Write something just to have something on paper. That doesn't work either. That's not what we're in for. Look at other plans, take what works for facilities. I must say, I think Khayelitsha's plan, really some good things coming from there. Beginning at the end and end at the beginning. What I say about what I want to say about that is actually just the action cards. We've now done all the action cards for the different places, and then we are going back and rewriting the plan, because the action card actually gives the detail, and you don't have to write so much into the plan now, because everyone knows what they are doing. So start at the end and end at the beginning. So the new plan. Let me just see my time. I'm almost done with this part. The new plan is a final document to be signed by the CEO, you, because you were involved, the OHS practitioner, and then it goes to Dr. Wayne Smith and his team to scrutinize it and actually sign off on that also. So that's the process. We made a very thin red folder from this document to leave at the nurses' station. And then they also have a major incident wall in the ward, where they put up the action cards and their different nursing allocation cards, and put small blommetjies around it, or whatever they want to personalize it as. And that's very good, because, like I say, one major problem is to keep this alive. Action cards important, I think. Also to involve your hospital leadership in that. They've got specific action cards that spell it out for them, what they must do. It's also empowering them to know that they are going to do the right thing on the day. And they can trust us to support them in that. Then a 2-yearly review, basically, training program for all the personnel. Your OHS practitioner is probably very involved in that, because they have to also tick boxes in terms of their training that they do. The follow-up is a tough one. Who is driving the process? It must be your hospital leadership. It cannot be you, because you get involved in other things again, but you can still be the advocate. Spot checks. I walk to the wards, especially a few months ago, I walked into a ward because we had a small incident that I'll tell you now about. And I asked the nurses, if there's a fire in that ward right there now, what are you going to do? So small spot checks. I just put people on the spot and ask them, do you know how to use this fire extinguisher? And it's not the fire marshal, because the fire marshal is not even on that shift sometimes, and funny things like that. So nothing like a small incident to remind people of the value or the need for an internal major incident plan. And that actually happened recently with smoke coming out of CSSD here with us. I remember Heike sent me a WhatsApp very quickly to say, are you all right? Because the command medic hears about it very quickly if something like that happens. But that led to quite a good process of us really just evaluating the whole plan again, getting buy-in from everyone, like I said, and that's hopefully going to benefit in the future. Yeah. So now just the last few seconds on external major incident plans. Get yourself 2 cue cards and a disaster room. It is, after all, part of the ideal hospital that you have to have these things. It's a lot of work. Get some help somehow, and sometimes it's your night staff that can help you, a very keen person in the EC. You stock it with enough stuff to have the surge capacity. You go according to your external major incident plan. You regularly do training with your team of doctors. If Metro calls you right now and say that there's 50 patients on your doorstep, what to do next? So I won't go into detail, but it's just very important that your senior doctors know what to do. If you are like us, many of the things you do every day relates to external major incident principles, like decongesting packed EC on a Saturday afternoon. There's just no more space. So what do you do? These are things that you learn on the job. Having enough stock and consumables for the end of the month weekend, that reminds you of the external major incident preparedness. And like I said, we are actually living many times in a slow external major incident, because what do you do if there's 40 unseen patients waiting for 10 hours to be seen? And you must really just think out of the box the whole time. So this prepares you hopefully for a external major incident. Okay, sure. Can I have questions?
Sorry about that. Actually, Martin, this is a question for you that maybe you can defer to someone. Okay. Is you mentioned that a major incident plan often, on Saturdays, it looks like a major incident in most facilities. How does major incident planning differ from surge capacity or overcrowding plans? And Charlotte's nodding as if, because that may be a question someone could ask.
Oh. So let me repeat the question. You're saying what is the, so we're talking about external surge capacity basically, is that, we are defining it. So
yes, so we have to plan for surge in the same way that we plan for major incidents. So is there a particular difference for those things, or are they all part of the same plan or same spectrum of planning?
Yes, my thinking about it is there is quite a difference. Certainly, I've got an influx of patients here that is steady, and I can measure it also by waiting times, for example, and also amount of doctors I've got on my shift, just to think a little bit. Am I going to cope with this? The acuity, is there just red patients all over? That is the slow major incident that we talk about. But a major incident plan, I think, speaks specifically to external major incident that happens, like the big fire or a big bus accident suddenly, or the stampede at a soccer stadium, or a gang war suddenly, and we get that, and these guys are coming for us. Metro calls us and says that you are expecting 50 patients now, and ETA is 15 minutes. And that's a bit different.
So I see Charlotte's got her hand up. I was going to respond as well, but maybe I'll wait till after that.
Yeah.
That's okay with you?
I think, Heike, you can first respond, and then I can see how far on the mark I was going to be.
Okay. So I think Martin, you made a really good point, is that it's part of the same spectrum in terms of how you think about it. Your approach to surge and overflow and capacity relies on the same principles, so that you would for a major incident plan, right? I mean, this is the stuff that we're familiar with. I think what's important to note is not necessarily that your major incident is external, is that your trigger point for activation is often a single event, or it's and the trigger point is very clear. Whereas in surge, the kind of weekend peak, it's often subtle, and the trigger point for activation or change is often much more blurry. And so that's why it's often harder to implement. Everyone wants to come out for the big fire and the stampede. No one wants to come out on a Saturday night because you're 40 behind. So there's a lot of human factors around it. And command and control for surge and overcrowding is often more challenging than for a major incident, because the sense of responsibility often doesn't move from the EC or admission areas to the hospital in the same way as it does in a major incident. And so some of the lessons that we can learn about surge and overcapacity and all of these challenges is to define those trigger points in the same way as you would in a major incident plan, to make sure that you have hospital management engaged in the process. And so it's not an EC trigger, it is a hospital trigger with set targets and goals and responsibilities. And I think that's where we fall flat, is because we don't share the responsibility when it's surge in the same way as we do when it's a major incident. So that was just my thoughts.
Charlotte.
Sure.
Oopsie. Can you hear me?
Yeah.
Yes, I think that's pretty much similar to what I would have said. The only thing I could add is that maybe within a major incident, patients are less diverse. So for instance, if it's a bomb, you know to expect what kind of patients are coming, caustic ingestions or trauma or blast injuries, where they're less diverse in their presentation to surge capacity. Where surge capacity, it's still a very varied, diverse population or type of illnesses presenting. Both can probably be divided in between acuity. I mean, you're going to have your walking wounded, you're going to have your stretcher cases, and you're going to have your severe acute polytraumas, for instance, if it's a blast injury. Whereas with surge capacity, there's not necessarily going to be easy detectable, okay, this is the type of presentation patients are coming for. It might still be the very acute neonate versus the elderly patient, whereas in a major disaster incident, it's often easier to say, okay, what we're expecting is polytrauma or burns or acoustic injuries, which makes it, yes, you've got less time to plan for it, but you can anticipate what's coming in. Whereas surge capacity, you don't have that luxury. It's not a clearly defined incident that's coming in.
I think that's a very good point. I think my illustration on that is the earthquake that I experienced, the major incident. We were 12 hours away from the epicenter, but the point of the matter is we expected polytrauma patients, and we could implement something like the sonographers being at the door and literally doing the EFAST on every patient that came in there, because mud walls fell on most of these people. So we had blunt trauma, lots of blunt trauma, and we could quickly implement something like a sonographer right there at the front door. As the patient came in, they basically got an EFAST as just part of the ABC. And you can't necessarily do that with the surge capacity. I must say, I'm very encouraged about the workplace where we work, because there are so many times that we on a Saturday afternoon or a Sunday morning, we put a message on the senior clinicians group, and that's all the consultants of the hospital, and we just state our case. We say basically this is our waiting times, and these are the patients we still have to see. They then basically look at their workload in the departments, and they send us doctors to come and help us to see patients. And that is something, I don't know how many hospitals can say that, but that is something that just by cooperation we create very quickly surge capacity in that sense. Okay, shall we move on? Let's move on. So I'm going to just share again my. So let's quickly talk about the pre-reading. Did anyone find anything that you felt, yo, this is good? We are going to send you 3 more documents. It's the Western Cape documents. I'll tell you a little bit more about that, but just the Western Cape documents in terms of how to prepare your facility for COVID. And then also the third one I thought of was the Ideal Hospital document, just so that people can have a look at it. It's probably, you'll say, oh, it's a big document, but just see even the categories that is covered in that document. Anyone with specific comments on the pre-reading? Anyone?
Martin, can I
Yes.
ask if you could maybe speak to the usefulness of these kinds of guideline documents that were sent out, whether it be from the Western Cape government, from the Gauteng Department of Health, the Western Cape Department of Health, or the CDC? What is the value of these kinds of documents for each individual facility? Because, you know, these guidelines don't speak specifically to Mitchell's Plain EC or Kaya EC, and each EC varies. So where then does the value of these kinds of broad guidelines and recommendations fall into the disaster planning?
Yeah, so I think it's important that my idea with this afternoon is also for you to think about your future unit and your future facility. So don't think so much maybe about what. Yes, certainly we will discuss it now, what you've experienced, but the aim is also to think about you are now going to Beaufort West or something, and you're doing a locum there, or you are moving to where there's a new EM physician post and what to do there. So maybe I'll just go on quickly because I'll give you some highlights, and maybe that's asking Lauren's question in itself. I think the CDC document, it's just, my idea is also just to give you different documents, just to see what the Americans came up with and what we came up with. So sorry you didn't receive the Western Cape ones, but you'll get that afterwards. Yeah, and one page that was good for me out of the CDC is healthcare services surge capacity and a tick box thing there. So many of these things are tick boxes that you can actually just see if you are covering all the bases. So I think that is an important thing, Lauren, that I think, and also what we experienced is some of these things are intuitive. You go through the process and you say, yeah, I'm faced with, we have to prepare our facility. We talk to the different people. We maybe get together and have a meeting. But many of these things are intuitive. You realize that you have to start slow because the pandemic is going to start slow. It's not necessarily going to be 200 cases on day one. It's going to be 2 cases or maybe 1 case a week, and then it's going to. So that's an intuitive thing where you think you have to bring that into your planning. Things like that. We can chat in the groups more about that. So CDC, a tick list for actually how to almost have surge capacity. WHO hospital preparedness for epidemics 2014. There's a lot said, and like I say, 2014. So what does that have to do with what we experienced? I think I like the document just because it goes into the different areas that you have to keep in mind. Again, just to almost give you a mental framework to go by, and then many of these chapters go actually into a framework where they say the goals of what we are going to discuss, 2 general principles or 3, and then basic requirements for that. Let's say number 7, hospital pharmacy, basic requirements. And then preparedness tasks, so beforehand, the response tasks when the epidemic hits us, and then also afterwards the recovery task that we should actually now think of looking at, you know, and that's that's the last question basically of that we're going to discuss. So yeah, rapid hospital readiness checklist. It's again a very nice checklist that just makes you think about the aspects. There's 12 key components. So again, Lauren, I think just to look at these different things and say, yeah, we are covering these things. The Gauteng document that I sent you, it's just a nice one to look at the picture, and it says, and if you look at this picture, you'll probably say, hey, many of the facilities actually did it this way. There are some of the facilities that didn't completely do it this way, and certainly Mitchell's Plain, we had to adapt, and we did. Sometimes we did the whole COVID PUI ward of the hospital, and sometimes now we are at the stage where we're not doing that anymore. So just to say that you will also change, but you will have the components, and you will have to think it's probably a good idea to have these components in your planning. So and to find a spot for them. That's sometimes the big thing. The Western Cape Circular H68 that we're going to send you spells out the Western Cape kind of framework. There's a nice picture of the national strategy and versus the Western Cape one, and it spells out these 4 components. So suppression and containment, you have to have a whole plan for that. You must have a mitigation part where you have hospitalization as part of that. Your patients, where do they go? And then the recovery and vigilance, where it's the end. And then unfortunately also the adverse outcomes part in the middle, where you have to think about capacity of your mortuaries and the burial processes and speaking to your undertakers. I think that helped a lot. Something from the Western Cape Circular H77 that we're also going to send you is actually Annexure C, which I think is one of the things we're going to keep on doing in the future, and one of the things maybe we will keep in mind after the pandemic, and that is that individual risk assessment process for our staff. And I think it's quite good to keep that in mind, and we talk about having TB, but do we think this way necessary of putting a very high risk staff member next to TB patients in medical wards or in the EC for that matter? Maybe we thought of that, and certainly public health people thought of that, but are we thinking this every day? And I think this is something that happened to us with the major incident where we definitely said, we can't just put high risk people in a very high risk area. So 2 specific things: employee vulnerability and employee exposure. I don't know how many of you have seen this. Certainly for Charlotte, this is something I think that is very relevant and good to have a grasp on for answering a question about this. Yeah, and it's basically a score that you work out, and then you decide where are you going to put your staff. And certainly it brought us some difficult times also, because we can't just say, we've got 10 staff members and 5 of them are high risk and 5 are not high risk. It doesn't work like that. Sometimes it's 7 high risk and 3 low risk, and then you're in trouble. Or so it certainly brought its own challenges, but it's a good thing. Yeah. Any questions? Anything? Any ideas? Any suggestions? Yeah. Otherwise, let's do the groups. Okay, so we'll give feedback. Everyone back? Yes, yes. Coming back?
Yes, sorry it took so long.
Thank you. We also. Okay. Group 1, question 1 and question 2.
Is that us now?
No, group 1. We are group 3.
No, you are group 1.
Okay, Charlotte, go. Question
Sure.
1 and 2.
Okay, so I'm just going to quickly bring up the broad pointers. I'm not going to go into much detail, but what we discussed with question 1 was saying that it's a very evolving process that evolves as the pandemic evolves, and that you have to anticipate that it's a reaction. You're going to react to what is needed from you. But very important that there needs to be a staged response with clear triggers. So you have to be very clear in saying, when we have this situation, we are going to escalate to this. When we have this amount of COVID patients coming in, we are going to change our setting to this. So very clear staged response and set triggers. Then we said that the main aim, a lot of the main big aims would be risk reduction and decrease of infection spread. So trying to limit, to have two different kinds of flows, patients with high risk and patients with not with a low risk for COVID. Protection of your PPE and smart or efficient use of the PPE, and that comes down to buy-in from the higher systems. So closing down elective surgeries, not having unnecessary students using up your PPE, educating the public so that they are educated and know what to expect that's going to happen from the EC before they actually land in the EC. And then with regards to risk assessment, also intelligent distribution of your staff. So having low risk staff with high risk patients, or using your different, say for instance, non-emergency medicine staff in efficient ways and in intelligent ways. Then with regards to the control in the EC, very important to have a balance between treating the pandemic, but also continuous care of the non-COVID patients and the non-COVID flow. Then with regards to another important things, we said communication is very important, and then anticipating the non-COVID complications of COVID. So we were saying, that you might have the peak of your pandemic happening at the same time the peak of your staff illness is happening, and how are you going to anticipate for that variability, and that, for instance, lack of staff at the same time you have the highest incidence of sick patients. Also, that there should be alignment between your staff and systems. So it's no use having 50 extra ICU beds, but no ICU nurses to actually man them. So having a clear parallel between your staff and your systems, management of your resources. Understanding that there might be the other components of the pandemic, not just the disease itself, but understanding the mental and economic complications and possible impact that might have on your community and your unit. And then understanding that there's going to be a time that we've de-escalated the elective and the clinic treatments, but anticipating that there's going to be a need when the peak is coming to an end, where you have to re-escalate this care in order to make sure that you don't, sorry, my daughter.
Hello.
Sorry, that you don't waste time still being in pandemic mode, where there's a great need for the elective clinics and all of those resources to be starting up again. And I think that's basically what we were saying about pandemic planning.
Yeah, you covered some nicely what we said. Also, question 2, also what we would have done differently also. Yeah, I think we've covered both questions. Yeah. So, shall we go to question 3 and 4? Anyone want to add something specific? Question 1 or 2? Can we move to question 3 and 4? Okay, let's do 3 and 4.
I'm going to be answering on behalf of my group about question 3, whether it was a good idea to split the ECs into, well, a dual stream EC based on the guidelines of the Cape government. We had a few ideas about why it was mostly a good idea, and a few things about why it was a disadvantage. Okay. So basically it was quite a good idea in terms of the policies that they've learned from previous pandemics. I think it was the influenza pandemic that suggested splitting ECs into a RESP or a non-RESP, or a hot or cold or red or green, or whatever each EC decided to call it. The advantage of it was that it actually made people more aware or more vigilant being in the ECs when there are PUIs around. So they would be more conscious of wearing their PPE, taking precautions, wearing their N95s. Also, it actually made them feel a bit more safer in decreasing their anxiety. And then because it was split, you're not always working in the hot area. So you don't have that constant anxiety or that constant feeling of like, I'm working this hard in a hot EC all the time. So you had a bit of a break from the COVID EC when you're working in the green EC. So it improves coping mechanisms. The disadvantages we found were that there was increased risk of healthcare workers being exposed to silent PUIs, and then also the risk of spread to silent PUIs to non-PUIs, which will increase the risk of spread. And then also sometimes there's a false sense of security that now in the green EC you don't need to be that vigilant. And then the biggest advantage we found was splitting of the resources. So you're splitting your equipment, you're splitting your doctors, your healthcare staff, your nurses. Then in some equipment you don't have two of, like you don't have two blood gas machines, you don't have two ultrasound machines. So you've got to be very vigilant in terms of which equipment, where you're putting your equipment, and what is more important. So it's very difficult to be spread that thin. I don't know if there's anything I forgot. Oh, also the one thing we realized is when you're working in a hot EC and everything is just COVID, you forget that other things can happen like DKA or MIs or CVAs. You know, just not everything is pulmonary edema, not everything is COVID. Yeah, it was just a few things. I'm not sure if I forgot anything. Yeah, that's about it.
Anyone else? Davi?
Sorry, Martin, I've lowered my hand.
Okay.
I'm sure I did. No, it's lowered.
Yeah. Okay. So yeah. So very interesting, and I mean, there's so much to say for both of those sides to split or not to split. The nice thing to talk about it now is that we've probably experienced it ourselves, so we can say. Yeah, especially the one thing that is important is it's visual, but it also means that you're probably saying the person in the non-COVID area cannot have COVID, and that's the worst thing you can say. So I mean that's probably something that we must work with, and yeah, we must just be aware that is whatever we do as a split anything. That we should not say a trauma cannot have an MI and an MI cannot have trauma, and the same with COVID and non-COVID streams. So, yeah, anchoring. Okay, question 4. I think we don't have to even do question 4. We've certainly our group have talked a lot. If you were tasked to lead your EC's COVID-19 response, what framework or factors would you distill from the pre-reading? I think you can go and look at it yourself. Yeah. Like I said in my introduction, I think there's really lots of good tick boxes. And I realized when Charlotte said in our group about the mental aspect, it is in most of those tick boxes that you must look at the mental aspect specifically in terms of mental health care, also the patient, but also specifically about your staff and their mental health. So yeah, just the tick boxes I think is quite good. Okay, anyone? There was a hand now.
It was Kefas's hand.
Kefas.
Yeah, so no, I just wanted to add about the splitting and unsplitting of ECs. Just one thing in addition to what my colleague mentioned is that there is also another way of measuring whether our splitting was really necessary, you know. So some of the things we can look at is to see if we had any indicators for splitting, what were we trying to achieve, you know, understanding that when you split these ECs or COVID into non-COVID, if in your non-COVID unit you start having a lot of COVID patients diagnosed from a non-COVID, that becomes a red flag that probably your splitting is not working very well. If you start having a lot of health worker infection, you know, workers not coming for work because they are infected, that in itself becomes a problem. It means that you're splitting where you're trying to enhance their skills, infection prevention, then it's not working. So we need to look at those numbers other than the overall, infection fatality rates, overall reduction in number of patients coming in with COVID, our improved case management. We need to look at some indicator of some form to know whether our surrogate splitting was really helpful. So I think we are going to have more information regarding that, which will be more objective, probably from the qualitative data experiences that these institutions are going to write about. But so far, it looks like overall, it looks like a good thing.
Okay. Let's quickly move on to the last one. In your opinion, what changes implemented during the COVID-19 response should we keep and continue to implement post-COVID? Is there something we can go on with? And I mean, we had a long list. So yes, group 3.
Yeah. So we discussed this, and we tried to structure our answer into an input, throughput, output type approach.
Okay.
So from an input point of view, what we liked about the COVID period was that we had this increased sense of screening and triaging of patients. And there was a tendency to have a clinician-assisted triage or a clinician-assisted screening. And this allowed us to flag patients quicker and deal with sicker patients quicker, which is something we'd like to carry forward into the post-COVID era. From a throughput point of view, I think there was a lot of emphasis in this period of time on hygiene, and it's something to continue with, not something that needs to come to an end. So in terms of either using dual equipment, so having a clean or a dirty ultrasound, for instance, or just performing basic hygiene on yourself, on your equipment between patients, and emphasizing that to your staff and to your colleagues going forward. The role of PPE is always going to be something, and the rational use of PPE going forward is important. Also, critical skills. So we talked, for instance, about using video laryngoscopy and full PPE when we intubate, and having that state of mind where you continue to fully protect yourself and your colleagues when intubating in the post-COVID era, where we might not have screening and patients might have MDR, TB, or other at-risk diseases, and making sure that you don't have an at-risk staff member performing these high-risk procedures. We also talked about transition of patients through the unit, so that goes onto our outputs. And because we knew that there was a surge coming, there was sort of a better flow of patients through the unit, and each unit in our group addressed it differently. So certainly in your own unit, you'll have to find a way of addressing flow and disposition of patients and making sure that flow is maintained. Whether that is your referral system using Hectus, sending patients to the ward, or to, like we did in Mitchell's Plain, to the overnight COVID room, and patients being disseminated from there throughout the rest of the hospital. We also talked on the output about our intermediate facilities that came with use, and how it's increased our bed capacity and therefore also decreased our EC stays and our borders in the EC, and the relevance of that going forward, whether it is having more intermediate facilities or just overall having more bed capacity by even more hospitals, etc. That's something we'd like to pursue and put, probably from a leadership point of view, put pressure on governments if we can access that at all. Other thing that was important with regard to output was the fact that we didn't have visitors, which did improve our clinician time with a patient. You weren't interrupted, even though the phone rang all the time. But what was nice also, like in a unit like Mitchell's Plain, is we had that forced, you needed to tick that you did call the family, and, you know, properly disposing of a patient by closing your communication, either with an awake patient, or if the patient was delirious, confused, low GCS, then closing your disposition by communicating to the family with, this is where your patient is at, and this is the plan going forward. These were just some of the things that we thought important to implement in the post-COVID era.
Sure. Very good. Yeah. Anyone else want to add anything there? we chatted a little bit about the ICU priority score. So we had a long chat, and yeah, I must say, yeah, Dawie made the point that it's not. It was developed inside the pandemic era, and we also, I think we agreed that it has got some application for post-COVID. Just in essence, to be able to chat to ICUs, what to say, how to go about thinking about if a patient has got a higher priority for ICU or not. So yeah, our valued staff we mentioned, sure, intubation team, also even the Boyke mentioned the visual interaction with patients with a tablet, for example, thinking out of the box and doing those kind of things. That was, yeah. But very much, yeah, thanks. That was good. Okay, so shall we quickly finish off? And it's, I'm just going to quickly share my screen again. Southeast Asia coming our way. Incubation period is 21 days. What was the incubation period now? Anyone?
10.
Okay, 10-ish. Mortality rate is 7%. What was ours?
5.
Let's say 2, whatever, but it's higher. Airborne not confirmed but suspected. You remember the time when we said, oh, is it really airborne or not? There was about a week. I remember the 1 week that people were saying it's airborne and what. Yeah. Thanks, Candice, for joining us. I know you have to run. Thank you. Yeah, and silly scenario if weather conditions ideal. So how will this change your whole thing? Or let's say just the fact 21 days, 7% and airborne possible. How will that change? How will that change what you do and what we've all discussed now? So, Charlotte, you want to say something?
Sure, I think first probably that would come from a governmental point of view, but shutting our borders. You know, if you think this is going to be a high impact pandemic or situation, you'd want to limit the influx of possible infected patients. So firstly, you want to basically change the movement or limit the movement of people, and especially people coming in that might expose your community to it.
But we did that.
Yes.
Okay, so
I missed the question of what you'd be doing differently, or
yeah, just some of the things that would be. We've now talked about a lot about what we have done, and I think in many ways we were successful in what we've done. But how would these 3 factors, how would this influence what you would do?
So I think probably anticipating from what we've seen in China and the rest of the world, where we know colder areas would probably be higher at risk, that the patients were sicker in the colder areas. So as we were actually going into winter, and that's why I think we prepared for the worst, which was good, because we anticipated winter actually playing a big role, saying that combined with our usual influenza and our usual seasonal, you know, it was actually quite in line with our gastro season, as well as going into winter with our transitional influenzas, etc. So I think we did that well. I wouldn't, you know, do it differently. We did anticipate that this is going to have an impact on the pandemic severity and impact. So that's with regards to the weather. Sorry, I can't see the question anymore.
Yeah, it's just if we think about a high mortality rate, a longer incubation period, and maybe something crazy factor like suddenly airborne.
Yeah, so airborne, I mean, then you'd have to be very vigilant about having negative pressure rooms, having the patient in negative pressure rooms, the say 1 meter or 2 distance between patients, not having them on top of each other. We already did the splitting of the EC to try and minimize that or mitigate that. And yes, I think closing down the airfare and the public transport would maybe then have been taken more seriously, or
earlier,
maybe earlier, limiting large congregations, more than 50 or 100 people, maybe earlier. We do know that, I think it was Sri Lanka, had like one lady bringing in COVID, and actually just by spreading it within one, funeral to thousands. So putting some, putting those things in place. What was the other one? It was airborne, the weather and?
No, airborne, longer incubation period.
Incubation period.
And high mortality.
Long incubation period. The importance there would probably to stress the education of the public. So saying, yes, you don't have any symptoms, that doesn't make you low risk. So everyone is basically being seen to be at risk for COVID or having COVID until proven otherwise.
Yeah. Okay. And high mortality?
I think, does someone else want to go? But I think maybe anticipating then that, there is going to be stricter risk stratification, who gets into ICU, resources are going to be limited with regards to the high acuity of patients or the high mortality rate, and maybe something with regards to morgues being overrun. And anticipation of that, I know in the Western Cape, we did set out the ice rink. We did make precautions for that. We did take measures to anticipate a high amount of deaths. Yes. I think maybe what the public didn't do is anticipating that. What would happen to my family if my breadwinner dies of COVID, and what would my backup plan for that indicate? And I think that's where the high acuity of mental health diseases came into play. I don't think, it was always kind of, it won't happen to me, it's going to happen to the neighbor, but it did then happen to you, and what the impact was on your own little family structure.
Anyone else want to add something? Just think about these three factors, what we said in terms of preparation of our unit. Anything else?
Martin, I just think if you think of the longer incubation period and it being airborne, you'll have to treat every patient that comes in as a possible PUI, because they might be asymptomatic, and I'm assuming it's a relatively new virus, so we don't know how soon are you infectious, and for how long, and whether testing is up to standard as of yet, and how available that would be. So you would have to have all your staff members in full PPE the whole time, and that you would have to set up your shifts so that you have staff on the floor, let's say for shorter periods of time with longer breaks in between, because once you're done, if there's nothing, you can't do anything except see patients, and then just to
go to the toilet.
Yes, and then just to
emphasize
the importance of PPE and wearing it adequately, and then also have a buddy system where you are very vigilant of checking each other getting dressed and donning and doffing to ensure safety of your staff, and then also maybe limit your shifts in a row to try and prevent fatigue with your staff to preserve the resources you have.
I was also thinking, and I just want to illustrate that you have to think on your feet, and that's what we did with this pandemic. Lots of things that we can now say we couldn't say in the beginning. We just didn't know. So I just wanted to illustrate that if you just change the things a little bit around, then you've got lots of factors and lots of knock-on effects. One thing that I thought of that was not mentioned yet is that if one of your healthcare professionals get sick, they will have to be off for a longer period of time. Even if they are, if they don't have severe illness, they'll have to be off a long period of time. That will have a knock-on effect on staffing of your units, because if also even high risk exposure, they will have to be longer off, and lots of things could happen just by changing a little bit the parameters. the high mortality, I think, yeah, what Charlotte said is that it will really have a big knock-on effect in terms of, yeah, just the mortuaries and the undertakers, and yeah, and then the mental health of people and staff also. Okay, so yeah, that was that. I think that I just wanted to share you a screen. I ran this by some people. It's not foolproof, and you can't say that I said you'll get the question, but at least yeah, I think there is a lot of questions that can come from what we've discussed, exam questions. So the one we said in the beginning, how to write a disaster plan for your hospital, just taking it systematically through it. And the next question is, you have just been part of your hospital's COVID-19 response, and with a small task group under your leadership, need to evaluate the response. Maybe Henry used a method just to always have a framework how to answer this question, write recommendations on what lessons can be learned and what permanent changes can be made. That would have helped you to answer that question. Yeah, and then a disaster medicine question that we didn't do this afternoon, but yeah, just a normal disaster question. This is probably a bit too easy, but how will you manage being the first on scene for a disaster or a major incident outside, and then just describe the steps that you will follow. So just to say that, yeah, disaster medicine, especially if you've got an examiner that's passionate about it, can come into the exam. Yeah. So that's it from my side. I think that's